come to my attention that we are going to ACEP this year, and we've got a plethora of things that are going on. First of all, on day one, we're doing a thing after the keynote with Joe Sachs, who's the medical genius behind The Pit, with Noel Wiley, who is the acting genius behind The Pit, and myself. And we're going to talk about how we put The Pit together and get some of your feedback and just hang out and chat. It will be awesome. And we've got a booth there, and it's going to be big and large and huge, and we really want to see you there. We want to show you all of the new stuff that we've added to EMRAP and to Corpendium, and Stuart will be there, and Sean Nort, and lots of the faculty will be there. We'll be hanging out, fresh in the flesh, and we love to see you there so that you can tell us what's good and what's bad about what we're doing. We're also doing an educational program, and that is Monday afternoon. So a number of your EMRAP faculty going through some really interesting cases. We're excited about that. There's going to be merch. There might even be some Go merch, our global outreach, our non-profit arm. So we really want to see you there, mostly so that we can see you. And if you're not there, I'm telling your parents that, you're truant, because you should be there. Salt Lake City, it's going to be fun. Herbert, out!
September 1st marks one of the darkest days in world history, the official beginning of World War II, as the Nazis invaded Poland on that day. And Jan, I don't want to gloss over that horrible time. I think it's important for us to recognize it, but we are kicking off a new month, and I want to kick it off on a bit of a lighter note, because as I was researching September 1st, the other thing that came up was Lily Tomlin's birthday. Lily Tomlin was born on September 1st, and she has been the part of so many amazing TV shows and movies. My favorite is that she was the voice of Miss Frizzle on the Magic School Bus, a show that I have watched far too many times, and my guess is that many EMRAP listeners either grew up on this or they've watched it with their kids ad nauseum.
Yes, that's a good one. I haven't watched as much Magic School Bus as you have, I will admit, but I do have a personal Lily Tomlin favorite that I want to share, which was her role as Violet Newstead in 9 to 5, which came out in 1980. Great movie. Dolly Parton, Jane Fonda, they were a trio. It was a movie of a specific time that represents a lot of gender-related work themes that you just wouldn't see a movie like that again. But I just really enjoyed that movie at that age that I was, and still have watched it over and over again to this day.
It does date us that we both know this movie. We know that time. We understand that time period in movie making. It was like Working Girl, and you had Mr. Mom was going on, and it was all about kind of those gender role reversals of women actually going to work. It was crazy times in the early 80s, Jan, and I'm glad that we've moved past that. We no longer need to make those movies, which is fantastic.
Yes.
But Lily Tomlin really has been a part of so many incredible things. Not what we're going to talk about for the rest of our intro, Jan. We're going to get into a case. Let's hop on the Magic School Bus. Let's dive into something a little bit different. Instead of the one case that we're going to kind of work through, I've got two cases that really highlight a little bit more of the art of medicine than the actual science of medicine. So you ready to go?
Oh, yeah. I'm intrigued.
All right, let's get into case number one. This is a 52-year-old woman who presents with a cough and fever times 6 days. She says that she saw her PCP 4 days ago. She had a chest x-ray, was diagnosed with pneumonia, and she was started on azithromycin and sent home, but she hasn't gotten any better. She's been taking the antibiotic. In fact, she's almost done with her Z-Pak, but she still feels kind of cruddy. And her vital signs look okay. She's not tachypnic. She's not hypotensive. She got a little bit of a fever of 101. Oxygen saturation's fine. So when you see a patient like this who's coming back to you, who, I'll be honest with you, the diagnosis was pretty firm. I wasn't really questioning too much whether she had the right diagnosis. It was really a matter of, does she have the right therapy? So what do you do when you see a patient like that, Jen?
Well, I think you nailed the first part, which is I want to make sure we have the right diagnosis. If the therapy isn't working, question number one is this the proper diagnosis? So revisiting all of that, which you have clarified that this was clear. So I'm going to say that this was pneumonia. You've thought that through. So let's not spend time thinking that through. That is what it is. So then I go to what is the therapy? The therapy that she's receiving is azithromycin. Now, that is the therapy of a decade ago. And so now I'm worried that this is a primary care doctor who might be practicing in the past, let's say, not necessarily up to date with guidelines. So that's my next concern. Was that your concern as well?
Yeah, that was my big concern going into this, is that it's not that she has the wrong diagnosis. It's not a treatment failure. It's a failure of inadequate treatment. It's pretty well established at this point that azithro is inadequate. As you mentioned, we've talked about this a number of times on EMRAP, but it is important for us to address that piece of it. It's really easy for us to get this patient on the right antibiotic, so we could start her on a MOX or a MOXCLAV or cefpodoxime. And that's exactly what we did. We told the patient, we have to go to a different antibiotic. Let's start you on this instead. You look pretty good. You'll probably be fine in a couple of days. But she asked us, well, why didn't the Z-Pak work? And this was really the question that came up for me, Jan. How honest are you with the patient? Do you kind of make something up to protect your colleague, even though this isn't an emergency colleague, but do you make something up and say, oh, sometimes the bacteria is resistant? Or do you mention the fact that, well, actually your primary care doctor is practicing the medicine that was acceptable a decade ago? How do you address that?
Yeah, now you're getting into that professionalism, ethical space that is always a little bit gray, because we're not really taught, in X situation, do Y, then Z, blah, blah, blah. I think that, I feel pretty strongly that you should not throw colleagues under the bus. Things just don't, especially in front of patients, whether it's in a patient chart or to a patient themselves, it's not a good idea. It doesn't end up well for really anybody. So in my opinion, I think that this is that how do I not throw my colleague under the bus moment? How do I explain what's going on here? So I'd probably say something like, well, azithromycin is a perfectly good antibiotic and it covers some things. And it turns out maybe that you have one of those other things. And so we do have other antibiotics that cover other bacteria that we can start you on. So I would just move kind of forward into the future rather than spending a lot of time in the past about what's happened to this point, and just kind of move forward and not necessarily dwell on why it was wrong or any of that kind of thing.
Well, Jan, essentially that is exactly what I did. I kind of fudged a little bit past this moment. I said, sometimes azithromycin covers it, sometimes it doesn't. Hard to know what bacteria you have, but this is a little bit broader. The medication we're putting you on, you should be fine. And usually I would just leave it at that. But for some reason, something possessed me to call the PCP, which I'll tell you, Jan, I usually do not do. I mean, if I'm admitting their patient, sure, I'll give them a call, give them a heads up. But I put out a call and talked to the PCP about what happened and identify that there's this knowledge gap. Now, I said it kindly. I didn't call the PCP out, but I said, we've been prescribing azithromycin for years, but it seems to not really work very well anymore. There's some good updates, blah, blah, blah. And I think it could have gone a couple of different ways. The PCP could have just blown me off and said, how dare you? Or he could have kind of thanked me and we could have had this nice collaboration. And I very luckily got the latter. The PCP was very appreciative for the heads up that the patient had bounced back, had come into the emergency department, that we had started them on a different medication. And actually, they were really appreciative to hear about this practice change. They were like, well, I've been practicing in the community for 15, 20 years, hadn't really heard about any of this change. And so it's that identification that sometimes the knowledge that we get and that we see doesn't always filter its way down. In fact, the PCP even said, here's my email address. If you like, you can send me along those articles so that I can actually update myself. And I thought that was a really great moment. It almost made me want to call primary care physicians more oftenly. I'm not saying that I'm going to do that, but I want to now because it was a really nice collaboration. I just feel like it could have gone a different way.
Sure.
And one of the things that kind of came up, one of the residents asked me and said, if it does go a different way, if the PCP kind of blows you off and says, I'm going to do what I'm going to do, and I've been doing this the same way for years, do you then tell the patient that perhaps they should see a different doctor?
Yeah, that's a good question. I think I'm uncomfortable with that. That makes me feel uncomfortable at a gut reaction. Just because the PCP may have blown you off, let's say it went that direction, doesn't mean that they didn't hear you. They still may change their practice based on what you said, even though their reaction to you may have been defensive or may have been a blow-off reaction. They still may have heard the content. I don't see myself as the practice police. I'm not in charge of everybody's practice, and we're all human and make mistakes. I'm sure there are things that I might do that could be out of date, whether it's now or in the future. And so I don't want to be too judgy about other people's practice and what they're doing. Nobody's perfect. So I think people are allowed to make mistakes. And I agree, the best way to do it is to be colleagues and try to approve everyone around you. That's what we generally do within our own specialty. I would do it, as a courtesy to colleagues. And I would hope they would do it for me, right? If I make a mistake and I'm out of date, that someone would kindly tell me that maybe I need to do something else. So I try to take the higher ground and kind of look at it from afar and say, this is not my job to be, policing other people's practice. Now, I will say this is obviously a mistake. That's not a big mistake. What if it was more egregious? What if it was something that was,
exactly,
more potentially harmful in that circumstance? And then what do you do in those situations? I still don't think necessarily, this is my opinion, but I don't think it's my job also to guide the patient on their personal choices. I think it is our job, though, to work within a professional space if we think we have an incompetent colleague to do something about it. I think that that is something that we can do, whether it is reach out to their medical director, to their boss, basically, who is their supervisor, and to point out something about incompetent practice, or refer it to a medical staff office if there's someone who's on staff with you at the hospital. That's another route that you can go. What are your thoughts on those comments?
I think that's exactly the way to go. I think that this is a bit of a different time. There are less people who practice completely independently of a hospital system. So there usually is some way to get some feedback of, hey, I'm a little worried about this or that. The place where I will give a recommendation is if the patient brings it to me and says, this isn't the first time that this has happened, right? If they bring it up independent of me bringing it up and say they're not happy with the care, then I'm happy to refer the patient because I don't want them to fall through the cracks, and the patient should be happy with the provider that they're using. So if the patient brings it to me and says, I'm not happy, I'm happy to refer them to a colleague or something like that. But I rarely will bring it up de novo unless, like you said, it's something that's really egregious where you're like, whoa, that's not a safe way to practice at all, in which case I will identify that to the patient and I will tell them that they should probably look for somebody else and that I'd be happy to give them a new referral. But most of the time, they're not those major issues, right, Jan? I mean, most of the time there are minor issues, or it's an error, or it's not knowing that, the patient was started on this medication by another doctor. It's that continuity of care, having everything kind of put together so that everybody knows exactly what's going on. It's rarely such a straightforward, this person's practicing bad medicine.
I think that's right. I agree. If a patient were to ask me, I would answer honestly. If this also is a physician where in your group, that, Dr. whoever, let's just say Dr. Smith, everyone in the group knows that Dr. Smith makes, is like not a good doctor, like making a lot of, bad judgments here or there. It's kind of person. Then I think it's okay to also say, hey, there's another really good, person in town that I would refer you to. So I think there are some, other scenarios that we could play out along these lines that may have a different answer or a different solution. You always want to do what's in the patient's best interest. But just to sidestep a little bit, I also want to point out that I think, making very sure that none of this is in a patient chart is super important these days. Sure. Now that, patients have access to their records, they can read your notes, they can read everybody's notes. Very important not to throw colleagues under the bus or imply that people have made mistakes in the chart. It can only lead to trouble for everyone involved in the case. So being very careful to keep all of this out of a patient's record and to do it through other channels. If you do decide to send a message through your EMR, making sure it's not copied to the patient's chart, better to do it even outside of that to be safe. But those kind of thoughts come to mind as well. Other common ways that we step into the mud in these situations.
All right, I agree with you 100%. I think these are really difficult scenarios, and that's why I wanted to ask you, what do you do? I would love to hear what the listeners do as well. You can write us in, but let's go to case number 2. This one is a little bit more about the medicine, Jan. I've got a 63-year-old woman who comes in feeling anxious. Her vital signs, she's got a little bit of tachycardia, about 110 beats per minute. Her BP is 170 on 92, no fever, normal sat. She's a little bit tachypnic, but it's very mild. Her ECG shows sinus tachycardia. And I start talking to her and she says, I take alprazolam daily for anxiety. I missed the doses. I ran out and I really need some. And when I kind of piece together with her how much she's taking, she says she's taking about 10 1 milligram tabs during the day, which is quite a bit for somebody to be taking just for anxiety. And it started to make me think, is this person benzodependent? And what I'm seeing in front of me, because she says she ran out of her medication, she hasn't had it, is she in benzo withdrawal? So I started kind of the usual benzodiazepine withdrawal treatment, which is very similar to alcohol withdrawal treatment, Jan. We don't have to think too much for this. We're really good at it. So gave her some fluids, gave her a little bit of Valium, checked her electrolytes, and she started feeling better after the first 2 doses of my diazepam. We did a bit of a chart check. It does turn out that this patient has had benzodiazepine withdrawal before. There are some notes from primary care as well as inpatient that she has some benzodiazepine abuse issues. And now I go back and talk to the patient, not to confront her with all this, but kind of to come together with a plan. I'd like to bring her in, get her through this withdrawal phase, get her to treatment. And she says, no, I'm ready to go home. I feel great. I'm ready to go home. Just give me a script for my benzodiazepines and I'll be out of here. And, I know that's not the disposition that is the best for her. She would be better served coming in. But I also know, just like with alcohol withdrawal or alcohol use disorder, I can't make somebody want to quit. So forcing them into an admission isn't really necessarily a benefit. So I have to kind of respect the patient's wishes. I can send her home. But the question is, do I discharge her with the benzodiazepines, understanding that she needs the benzodiazepines to not withdraw, which is a life-threatening thing, but am I just fueling the issue that's at hand? So Jan, what do you do in these kind of scenarios?
Oh, this is a tough one. And I've seen this patient for sure.
I'm sure many times.
Yeah, I think many times. What comes to mind first is do no harm. I mean, we do have, some ethical obligations to our patients. I don't think that continuing to feed into her addiction, which I clearly have identified in your scenario, and and having the key to all this case is the discussion with the patient to explain what's going on. Your suggestion of I want to help you. This is how I want to help you. If you don't like my plan of how to help you, that's your choice. You can make your choice, but I'm not going in this particular circumstance. I don't feel it's therapeutic for me to give you a script for something that is, even if I give you, let's say I want to give you 5, I want to give you 10, whatever limited number, you're going to run out eventually and be in the same exact scenario. So what are you going to do then? For someone whose anxiety is to that level that they need that level of alprazolam, there are probably other effective treatments, which I would also allude to and try to make a bridge to that plan. So no, I don't feel comfortable giving this person more benzodiazepines. I'd like to make a plan to make sure they're safe, but I don't think there's any number of those pills that I can give you that's going to solve this problem. So I'm not going to do that.
And along with what you're saying, even if we said, well, this person is going to have a bad outcome if they withdraw from benzodiazepines at home, so I'll give them some benzos, but you're not going to be able to give them enough benzos to keep them from withdrawing forever. So you're just kind of pushing off the inevitable. But I don't think there's a right answer here. I mean, the ideal is to convince the patient she should stay, right? That would be the ideal situation. Kind of my backup was, well, let me engage with your family. No family came with the patient, and she wasn't really forthcoming of like, oh yeah, here's my daughter's number, give her a call. So that didn't happen. I do have her primary care doctor. And so it kind of comes back to that collaboration with your colleagues. Now, Jan, it would have really come full circle if it was the same primary care physician that I just had with the pneumonia patient. It was not, but I can definitely talk to the primary care doctor and say, hey, I'm seeing this patient with this. What do you think? Can you see her in the office tomorrow? Do you think that you would have more of an impact getting her to somebody else? If she's being treated for anxiety, maybe she has a psychiatrist. I can have that discussion with the psychiatrist. There are those other options. I was able to get her primary care doctor on the phone. I mean, Jan, listen, these are 2 cases where I spoke to the primary care doctor twice. I'm not comfortable with this situation at all, but I spoke with the primary care doctor. And it turns out that the primary care doctor actually had a very good relationship with the patient in spite of the fact that he knew she was abusing benzodiazepines. He knew about all of these issues. He's like, yeah, I've been having a really hard time getting her to treatment, but tell her she can come to my office tomorrow. He's like, I agree with you. If you don't want to send her home with benzos, I understand that. If you want to send her home with a little bit, I'll see her in the office tomorrow. Both of those would be fine with me, but just tell her she can come in tomorrow. Anytime, I will squeeze her in. We will work through this together. It was one of these kind of old school PCPs. I'm like, I don't know where you have the time to do all of this, but that's fantastic. And so I decided to kind of try to make a little bit of a therapeutic relationship with the patient. I said, listen, I'm going to give you this many of the benzodiazepine. I'm going to send you home. But your doctor, I spoke to them, they'll see you tomorrow and you need to go in. You need to go in to figure out what the next steps are, how to get treated for this, because we're not going to be able to keep giving you enough benzodiazepines and eventually this is going to end in a bad way. So again, we had that conversation. I discharged the patient and at least at the time of discharge, I really believed she was going to go and follow up with her primary care doctor. I don't actually know what happened, Jen. I didn't follow it up beyond that. And there are lots of reasons, right? I can say, oh, I just got too busy and I forgot to write down the information. Or it might have just been that I didn't want to be let down again, because how many times have we been let down by this process? But I think at the absolute least, we have to try something. So if we can engage with family, great. If we can engage with their caregiver, their primary doctor, great. Their psychiatrist, something along those lines. But of course, sometimes none of that works. And you have to make a decision in the moment. Do I give them some so that they don't withdraw in the next 12 hours and die? Or do I give them nothing and say, come back when you're ready to change? And I don't have the right answer, Jan. I just know what I got away with at the time, which was speaking to the primary care doctor and trying to set up follow-up.
Yeah. I mean, I think what you did, the warm handoff to the next step, would permit a plan as, giving someone a limited number with a plan for some kind of taper, but that you have somewhere for them to go. If there weren't that option of somewhere for them to go, then you know what's going to happen if you discharge someone without the prescription. She's probably going to go doctor shopping, go to the shop across town, get the prescription from somewhere else. That's on her to do. That's not going to be me that does that. But if I had the plan that you made, I like your plan. I think it's a great plan. If I could set up a warm handoff with somebody, I have a continuity of care that I can document. I'm going to give you this number to get you through that. I'm comfortable with that. I would do that. I do that all the time. So I like your plan. I really like your plan. You're a good doctor.
I felt okay with it.
Yes.
I felt okay with it. Clearly, I had a little extra time. I know a lot of our colleagues out there are like, how did you find the time to make all these phone calls? Remember, I have residents running around doing most of my work for me. So I had the little bit of time to make those phone calls. But I don't love the plan that I had. I just know that it was the best that I could do at the time.
Exactly.
And that's a lot of what we do in emergency medicine. It's a lot of what we do, right, Jen? I mean, a lot of what we do is this is the best I can possibly do. And hopefully the patient isn't worse off for it. And like you said, do no harm. And I think that's kind of the crux of this is I don't think I did any harm to the patient and I did the best that I possibly could.
I think you did as well. And you're right. Not ideal, but you have to collaborate with your patient. They're a stakeholder in this too. That fits into what she wants and her values. Sounds like the best you could do.
All right, Jen, so a little bit of the art of medicine, these two cases, not really like the hard hitting, this is exactly what you should do, but these are the conundrums that we face every single day when we work. I think it's good for us to chat about them. A lot of experience in the room, guiding how we practice this, things that we gleaned from our supervising physicians when we were training or other people that I work with. A lot of times I'll ask somebody else that I'm working with, how would you deal with this situation? And just make sure that I'm not being crazy with the way that I'm doing something. And with that, Jen, we're going to go out of the intro. We're going to go into the week because we have some great stuff ahead of us. We've got a medical legal segment with Mike Weinstock because it is the first week of the month. That's when we have these. So we've got that. We've got a piece with George Willis talking about HHS. But before we get into all of that, I want to give a little bit of a shout out to our colleagues who are going to be at EMRAP Live at ACEP. This is going on next Monday, September 8th from 2 to 4 p.m. in Utah. It's going to be an unforgettable session. We are bringing a powerhouse lineup. Mel will be there, Stuart will be there, Sean Nort will be there, Mizuho, Scott Weingart, Amal Matu, and so many more. So if you're at ACEP, drop by, check it out. It's 2 hours of your day. Mark it in your calendars. We can't wait to see you there.
Absolutely. It's always so fun. It's so fun to meet new people, and we are going to bring a great show to you. We've been planning it for a long time, so we'll see you guys in Salt Lake City, hopefully.